Hi friends, this is Vishnu here. Welcome to my channel Bees Medicine Diaries. In this channel, I am presenting to you various important topics in short, concise videos. So in this video, we are going to discuss about an important topic, that is intussusception. So let's go to the video without wasting any more time. So what is meant by intussusception? Intussusception is nothing but an intestinal obstruction. So what is the definition of this intussusception? Definition, that is, it is the invagination of one segment of a bowel, okay, intestine, into another segment of bowel. Okay, that is telescoping of one segment, usually the proximal segment of intestine, into the distal segment. Okay, so what is the etiology of this intussusception? Etiology, incidence. It is most commonly seen in the age group 6 to 10 months of age. Okay, it is most commonly seen in pediatric age group. Okay, I will tell the reason later. Now, what are the different types of intussusception? Structurally, there are three types, that is simple, compound, and retrograde intussusception. Now the question comes, which is the most common type of intussusception? The most common type is simple intussusception, and that too ileocolic, simple ileocolic intussusception, and it is followed by our ilioileal and colocolic intussusception. An add-on point is that retrograde intussusception is mostly seen in gastrojejunostomy, etc. Now let's discuss the pathophysiology of intussusception. Okay, based on the pathophysiology, it is of two types again. That is idiopathic intussusception, which is actually the 90% of intussusception, and also adult intussusception, or otherwise called as secondary intussusception. Okay, so first of all, idiopathic intussusception, which is mostly seen in the pediatric age group. Okay, why it is mostly seen in the pediatric age group? Okay, the most commonly approved theory is that it is due to the inflammation of Peyer's patches. That is, during this 6 to 10 months of age, when the baby is changing from breastfeeding to complementary feeds. Okay, when this complementary feeds comes, actually the Peyer's patches gets inflamed and hence enlarged into the terminal ileum. Okay, it gets enlarged into the terminal ileum. As a result, this peristalsis becomes very much complex, and hence the intussusception occurs. So that's actually a dietary factor behind intussusception. Another theory is that it is due to the inflammation of Peyer's patches, which is in turn due to some recurrent upper respiratory tract infections. Now let's come to the adult intussusception. Okay, it is mostly seen secondary to Meckel's diverticulum, polyps, tumors, etc. And hence it is called as secondary intussusception mostly. Now, what are the complications that can be seen in this intussusception? The most common complication is gangrene. Okay, the most common complication is gangrene. Now let's come to the various parts of intussusception. Okay, and intussusception, what are the different parts? Okay, we have four names to know. There is first one, intussusceptions. Okay, intussusceptions. You can relate it to the word recipient. Recipient, intussusceptions. Okay, so what is that recipient? Okay, the distal segment. Okay, the distal segment of the bowel, which is receiving the proximal segment, is called as the intussusceptions. Now, intussusceptum. Okay, intussusceptum is nothing but exactly opposite to the intussusceptions, that is the proximal bowel, which is entering into the intussusception. Next comes the neck of intussusception, that is, which is the narrowest part of intussusception, and that is actually more prone for this gangrene. The next part is nothing but the apex of intussusception, which is actually the most apical part, which is entering the distal bowel. Now, let's come to the clinical features of intussusception. First clinical feature is that continuous crying. The child continuously screams with pain. Okay, then vomiting multiple episodes, and there can be one attack of or one characteristic episode of red currant jelly stools. And another important clinical feature is that the child usually sleeps and then suddenly wakes up with pain. So these are the symptoms shown by the patient. Now let's see what are the signs, what are the clinical findings. Okay, examination findings. There are three major examination findings. First one, that is a sausage-shaped hard mass can be felt in or around the umbilicus. Okay, in or around the umbilicus we can detect a sausage-shaped mass. Another one is visible step-ladder peristalsis in the abdomen. And another clinical finding, the third clinical finding, major clinical finding, is emptiness in the right iliac fossa, which is also called as Dancer's sign. Now let's go to the investigations. So first investigation of choice is nothing but ultrasound scan, and in which we can get target sign or a pseudokidney sign or a donut sign. So these are very important names, that is pseudokidney sign, target sign or donut sign can be seen in USG abdomen, the investigation of choice. But the most sensitive, which is the most sensitive investigation, the most sensitive investigation is nothing but the CT scan, which shows the sausage-shaped mass. Okay, and another investigation that can be given here is barium enema, which shows a claw-shaped ending. Okay, claw-shaped ending of the bowel, as you can see here. Now comes the management. How will you manage such cases of intussusception? Firstly, we have to give Rein's tube aspiration. Then we have to give IV fluids, antibiotics, and catheterization. Okay, that is a general management. Now comes the specific management. There is first one, hydrostatic reduction. There is usually we use 1 to 2 liters of saline or barium sulfate solution. 1:3 barium sulfate solution. So it is poured through a catheter into the directly into the bowel through the rectum. Okay, and the pressure exerted by this fluid helps in reducing this intussusception. Another method of reduction is actually air contrast enema. Okay, here the air is pumped in at a pressure of 60 to 80 millimeter of mercury pressure. Now comes the need for surgical management. In case of adult intussusception, the surgical management is nothing but resection and anastomosis. Okay, the resection of the intussusception and anastomosis of the remaining bowel. Now, what is the surgical management in case of children? Okay, in children, we actually do Cobb's method. Okay, what is Cobb's method? It is nothing but laparotomy plus manual reduction. That is, we actually open the abdomen and then manually milk the bowel. Okay, in the opposite direction. And along with this milking, we use our little finger to break the adhesions and hence facilitate the reducing process. Okay, if the loops are gangrenous, okay, if the bowel loops are gangrenous, then we have to do resection plus ileocolic anastomosis. So that's all about intussusception. I have dealt with all the important points in intussusception. I hope it was very useful for you, and please subscribe to my channel and like the video and also share it with your friends. Thank you.